It is my distinct pleasure to introduce Mr. J.W. Hurst III, who will kick off the 2025 MHS Conference. Mr. Hurst is performing the duties of Undersecretary of Defense for Personnel and Readiness. As the Undersecretary, Mr. Hurst serves as the Principal Staff Assistant and Advisor to the Secretary of Defense, to include oversight of the military health system, force readiness, force management, National Guard and Reserve Component Affairs, education and training, and military and civilian personnel requirements and management, including morale, welfare, recreation, and quality of life matters. As an Army Reserve officer, Mr. Hurst brings a unique perspective and appreciation for the various types of employees who contribute to our national defense. His efforts are focused on enhancing the overall experience of service members, department civilians, and their families. Please welcome Mr. J. Hurst to the stage.
Well, thank you, Commander Nichols, for that introduction, and thank you, Dr. Farrar, for having me today. It's my distinct honor to be here. For those of you who haven't met me yet, my name is Jay Hurst. I'm performing the duties of the Undersecretary. I've spent about 5 years in the Pentagon in the past, 3 on Army staff, one is a legislative liaison for personnel issues, and 1 is a project manager for Project Maven, an AI project started under Bob Work. I deployed to Afghanistan 4 times with the Ranger Regiment. I worked for the JSOC Intelligence Brigade, and I've been to CENTCOM. And all in all, I've spent about 17, 18 years working for the Department of Defense. But I've been a military dependent for much longer. My grandfather was a Marine. My father was an Air Force officer. And when he moved us from Keesler Air Force Base up to Washington, D.C., I'll tell you some of my earliest memories are sitting in a Primus clinic where I had an ear infection or strep throat for like the 5th time in my young life. And I remember thinking to myself, maybe I didn't have the vocabulary for it, but this is good care. These people care about me. Later on, I was 13, and I knocked a hole in my elbow about the size of a quarter skateboarding. And I had a retired flight surgeon who took care of me, maybe come in 3 or 4 times, and I didn't want to come in to make sure my wound was clean and clear. Later on, I was in Yongsan. I was in Seoul, Korea on vacation when I was 20. And I just think that it was magical that I could take my dependent ID card and I could walk up to the post in the middle of Seoul, Korea while on vacation, and I could walk into a clinic, and 30 minutes later, I was getting antibiotics for a sinus infection that had been plaguing me for weeks during a trip to China. It was just disgusting. I was in China, and the pollution was terrible, and I was just coughing up black stuff for weeks afterwards. But that was great. And later on, when I commissioned, I went over to Afghanistan, and I took great comfort in being close to a Ranger aid station with qualified PAs and medics at Fob Shank in Rocket City. And I knew that our strike force was thankful to have a forward surgical team there that could provide care within that golden hour. They felt safer. They felt supported. They were willing to do their jobs because we provided the appropriate medical support. I had 2 kids at Fort Belvoir Community Hospital, the same place that I was born. My father was stationed in D.C. In 2017, 2019. And it wasn't until my last year in active duty in 2023 where I felt like something had changed in the military health system. I was in the Pentagon at that time, and I was working on personnel issues during the recruiting crisis, and I was working a lot of hours. And I remember the number of times I had to go to urgent care or the emergency room with my small children because I couldn't get a primary care appointment. There just wasn't the access that I've been used to for the rest of my life prior to that point. And I noticed that it was taking longer to get prescriptions. I remember one time I came to urgent care at Malcolm Grove, and they told me it was going to take 48 hours to fill my prescription for my sick child. My wife and I noticed it. It was a remarkable change, but the other thing we noticed was the people weren't any different. When we could get into a doctor's office, the care was excellent. The people were world class. But something else had changed. The resources, the availability of care, and I think we still have some of those issues today. And my message to you is this. I still believe we have the best people in the world, the best medical providers, but we're not resourcing you enough. And I don't think all our policies are supporting you giving the best patient care available. And so as long as I'm in this role, performing the duties of the PNR, I'm going to be your advocate. I'm going to ask for more money from Congress, from within the department itself. I'm going to ask for better policies and authorities to let you provide the kind of patient care that you want to provide. so we can be world-class leaders in medical care. But that's only one part of our mandate. We also have a responsibility to be prepared to support the men and women who volunteer to go overseas and fight our nation's wars. Our number one responsibility is making sure that our medical professionals are ready to provide life-saving care on the battlefield. It's a dual mandate. While we support the 9.6 million beneficiaries of the military health system, our service members, our retirees, and their families, we also have to hone our skills to make sure that we're ready to save lives on the battlefield. And we have a challenging scenario in front of us. We're looking at potential contingency in the Indo-Pacific. That's our pacing threat against a peer competitor, which in many ways is the most frightening opponent the United States has ever faced. And although we provided medical care at scale in the Indo-Pacific in the past, many of these dynamics are different today. The distances are the same, but the nature of warfare is changing. In World War II, we provided 1.5 million service members medical care through a network of 150 hospitals. But we had the luxury of doing that over time. We progressively took more terrain in the Pacific. We were able to build enormous amounts of hospital ships, and we slowly scaled our medical effort in line with the overall war effort. It didn't hurt that we're spending about a third of our GNP on defense at the time as well, which is something like $10 trillion today. That's probably not going to be available to us this time. It's also worth pointing out that after we evicted the Japanese in the Battle of the Coral Sea from the rest of the Pacific, we had pretty much full range to supply people where they were needed, and we had dominated the lines of communication. That's also something that could get changed in a contingency in the Pacific. In Korea, we were lucky enough to walk into that war with an experienced medical cadre. We had a lot of World War II vets who continued to serve, and even if they didn't go to Korea, they were training the people who would treat soldiers on the battlefield. In that war, we provided care through 25 hospitals and 7 MASH units to about 300,000 Americans who were part of that UN action. And then in Vietnam, we started to have a lapse in experience. World War II had ended 20 years prior. Korea was about 15 years before that. But we were able to slowly ramp up that war effort. In 1965, we started with a fairly minimal presence on the ground, and by 1968, we were up to 500,000 inside South Vietnam. And we developed skills over time to respond to that scenario. And we were smart about how we did it. We rotated in physicians and medics in small numbers in the individual rotation system, which has criticisms, but the one thing it did for medical personnel is we made sure that there were always experienced providers on hand to teach the green people who were coming into theater. Now, I will say this, the distances are the same for the current Indo-Pacific environment. It's still 7,000 miles or so from the west coast of the United States to the first island chain, but the nature of war is very different. And while in Korea and Vietnam and World War II, we basically could go anywhere we wanted to. There's no way for the adversary to affect us. And in this current scenario, we're looking at an environment where our pacing threat can affect us from the moment we leave the homeland until we arrive in the first island chain. We're under ubiquitous surveillance that's going to continue. We have less ships and mobility aircraft than we need to break into theater and to supply our troops. And everything has to be done in a window of time because of the threat environment. We're going to have to be looking for those operational windows where we can flow in supplies and medical units and also extract the wounded. We could be in a situation where field hospitals have 2 or 3 or 4 times the number of patients that they're actually equipped to treat. We're going to have to train our physicians to be able to ration care and triage effectively and keep people alive longer than we normally would expect them to under ideal conditions. This goes to the tactical level as well. If you look at Ukraine and what's happening there, some areas in Ukraine have as many as 500 to 700 drones over a single square kilometer. Maneuver is almost impossible. If you get wounded on the battlefield in Ukraine, you're probably going to get dragged into a casualty collection point or a field aid station that's underground. And there, medics and PAs and physicians, if you're lucky, will be working to stabilize you and save your life. And they might have to do this for 12, 24, 48 hours at a time, maybe even 72 hours. And they're just waiting for that opportunity, whether weather changes or there's the right EW environment or we have some kind of spirited fire, so they can pull you out of that situation and get you extracted to a Role 2 or Role 3 hospital. We have to train our medics for this. I was talking with the colonel yesterday about how he was training one of his medics to conduct surgery through the advice of a surgeon through augmented reality. And that's the kind of technology we're going to need in order to be able to provide life-saving care on the battlefield of the future. Something else that's different about this time in the Indo-Pacific is our allies and partner structure. In Europe, sometimes we take it for granted, but not only are all our NATO allies aligned with us, they're aligned with each other. And it's easy to shift resources amongst them. The Belgians and the French have habitual training relationships. They're happy to exchange doctors, they're happy to exchange patients or military equipment or supplies. We have mechanisms to do that. We've practiced this over time. But in the Indo-Pacific, it's not necessarily that way. Our allies and partners are only starting to develop those same kinds of relationships, and the distances impede that same kind of cooperation. And we're going to have to work through that, and we need to train that in joint exercises and try to incorporate more of that as we go forward. But probably the biggest thing we're going to have to overcome, and this is something I think we all can collectively work on, is that between 2005 and 2009, I think that probably the United States military was at its top of its game in terms of casualty care. We had so much experience treating casualties in Fallujah and Ramadi. There was a volume of patients there that we really hadn't seen since the Vietnam War, when it wasn't uncommon to see 400 wounded a day or more. That's 20 years ago. A lot of those people who provided care, some of you are in this audience right now, but many of you are very senior in rank, and you're preparing to exit the military. Others of you, you're in a position where you're no longer hands-on. You're in a position of leadership or administrative responsibility, but you're not necessarily there working with patients anymore. And so we will have some experience gap if we face a contingency in the late 2020s or the 2030s. That's a reality. What matters is what we do about it. And that's why everything we do for the military health system, everything we do for patient care, has to serve a dual purpose to prepare us for war. We have to make sure that we're seeing the right patient complexity and patient flow in all of our MTFs, so everyone can be as prepared as possible. We also need to make sure we get our doctors and physicians and medics and clinicians out to field exercises, and they're integrated into joint training exercises across the globe to give them valuable experience in the field, and we need to strain them. We need to go beyond what the capacity of these field hospitals are, these forward surgical teams, and make them work through scenarios they're likely to see in the Indo-Pacific. We need to strengthen our relationships with public and private institutions. We need to cooperate with the VA to make sure we have the surge capacity we need to treat as many patients as we can expect in a large-scale combat operation. We need to make sure that we're partnered up appropriately with the National Disaster Medical System so we have that crucial flow and that we exercise it. And we need to make sure that each day we're providing the people working the MTFs the best opportunities to hone their skills. Now, this isn't going to be easy. We're in a resource-constrained environment, and we should expect to be for some time. We have a large deficit, we have a large debt, but this is important. And at the end of the day, I'm still very optimistic about what we can accomplish, and it's for one reason. I think we have the best people in the world. I think our medical providers are the best people in the world, and our medical support staff is the best in the world. And the same kinds of people who helped me get over ear infections when I was little, or cleaned out my elbow wound from skateboarding, or gave me medical care young son when I was a dependent, are still there today. And so we just have to make sure we give those people the opportunity to exercise their initiative. I have a friend named Colonel Dave Blair now, and he's on the Chief of Staff of the Air Force Strategic Studies Group. He always likes to tell me that we win every single war when it devolves down to the level of the captain, the O3, because our people are the best at exercising initiative in the absence of orders. And if that's the fight we're in the Indo-Pacific, we should feel really good about it. But even in peacetime, we need to make sure that we're always giving those people opportunities to speak up to leadership and give us their new ideas and their fresh perspectives. And that's how we're going to get real change. Now, I think I've spoken for a good amount of time at this point. I guess I'll go to the audience for any questions you might have. You can ask me anything about resourcing. You can ask me about where I think the department's going. Anything's open.
Thank you, sir. That's a very motivating opening speech. So, thank you. All right. If we can bring up the lights a little bit.
Yeah,
so
we
that I
can't
can
see any of you right now. There we go.
Can't even see the microphones just yet. Okay, well, the microphones are all empty. We do have 2 online. Please, if you're shy and you don't want to stand up in front of the microphone, feel free to start writing away. So we'll start with the first one, sir.
Yeah.
What does the future of DHA look like from an agency standpoint? With the talks of DOGE, have there been any discussions about disbanding the DHA and returning the health assets to the individual military service branches? Not an easy one. Agitate. You were listening. Okay.
I asked for a softball first. I guess they denied that one. So I think if you look at what's going on in the department right now, we have enormous opportunities, okay? From the outside, it looks like there's a lot of change going on, and there is, and that's what our opportunity is, right? Right now, as we speak, we're doing a defense comprehensive review where the Deputy Secretary of Defense is going line by line through the budget to try to find efficiencies. And we have to. We shouldn't expect a great budget increase. We're not in that fiscal environment, right? DOGE is helping with that. And we have talked to them numerous times about the importance of continuing to provide world-class beneficiary care and making sure we're medically ready. As far as returning to some kind of pre-2017 dynamic, I don't think that's going to happen. And it's our job to make it work with the structure we have. There's improvements we all need to make, right, in terms of how the services are doing business, in terms of how DHA is doing business. We need good business rules. We need to make sure we can get people in the MTFs and then quickly out to the field to participate in their service training exercises. We have to balance these very commitments we have. We're in the 2017 dynamic. It's not going to change. But what we need to focus on is making sure that DHA is optimized to provide world-class patient care, and we're in total sync with the Surgeon Generals of the services, so we can make sure we're also ready to deploy on the battlefield and save America's sons and daughters.
Thank you, sir. The next question, still nobody is brave enough to come to the microphones. While enhancing our digital medical capabilities is needed to improve prolonged casualty care, what is your opinion on focusing on non-technical skills?
What's an example of a non-technical skill?
Well, I think there's the difference. They're asking focus on digital medical versus the I don't know, does the one who asked the question want to clarify? I could give my interpretation, but.
Yeah, well, I think everything needs to be done in balance, right? We have to embrace technology as we go forward, but we should never forsake our fundamental individual skills because it's not always going to be there for you. You're going to lose data link, you're going to lose connectivity. Everything we design has to be redundant and ability to operate in a denied environment. Just like I talked about earlier, I really think that scenario where we have people who are operating in underground bunkers is a probable one. We haven't figured out how to overcome the fire's protection balance at this point. Fires is dominant. And so we're going to have to figure out how to be able to conceal ourselves, use military deception, employee W, and that's going to preclude a lot of us having connectivity to the kinds of resources that we've all become used to. Even when you go into a doctor's office now, or, even at MHS Genesis, right? We rely on a certain amount of connectivity there in order to do daily operations. So we have to embrace technology and be able to exploit it when it's available, but also it's just like land nav. You got to be able to go from GPS to compass and map when you need to.
Thanks, sir. Over the last 20 years, multiple installations have closed, BRAC, and MTFs have reduced their scope from hospitals to ambulatory care centers or clinics. Do you anticipate further MTF consolidations or closures in the next 3 to 5 years?
I'll be honest, I don't know. I would say this. I think we have a military health system that's designed for a much larger military, which in some ways is a good thing because we have excess infrastructure if we need to surge. The bad part of that is there's many places in the MTFs where we don't have the patient flow we need to actually keep people's skills current. And there's other places where the demand is too great. Every organization needs to build cross-level resources, on an occasional basis, a periodic basis. I'd say we're probably in that time where we need to look at it. But every single thing should be case by case because, like I said, there are some MTFs that are over capacity and there are many others that are under. And we need to figure out how we can balance out private and public partnerships, making sure we have the right TRICARE network, in order to meet our patients' needs as we look at right-sizing MTF footprints. Yes, sir.
Mr. Hurst, Dion Trahan with App Global. Go Army. I'm a 2004 OIF vet. My National Guard unit in Louisiana, 256, was deployed with the 1st Cav, 10th Mountain, and 3rd ID. My question, sir, is around the McFamily programs. So I know from personal experience, when you're downrange and if you don't have food in the fridge, or your military spouse can't find a job, or your special need kid can't have any intervention services, all that distracts you from your primary mission, whether it's scanning your sector, planning your op order, whatever the case is. I know the Army Chief of Staff, General George, mentioned about improving food nutrition on posts, right? Too much salt, too much sugar, low quality source proteins. I know Sergeant Major Mike Weimer also expressed sentiment around improving base housing, right? Can't have mold and HVAC systems. Just kind of improving that morale of the loved ones back home. Internally, we call that Project Homefront. But, sir, I was wondering if you could just have some thoughts around supporting our service members on the home front so they can be as focused and, in turn, as lethal and resilient as they can be on the battlefield. I'd appreciate that.
Yeah, well, thanks for the question. This is one of the core missions of personnel and readiness, right? To make sure that we're taking care of our military families. And your point about nutrition, I would say this is a societal problem at this point, right? RFK rightly is saying that a lot of the ingredients in our food is not as healthy as they used to be. We can prove that. That's also something that's occurring in military installations. And then people talk about access to food on military installations. When we're doing these rotations out, I was just at a 4th ID, and we're sending people out to the southern border and to Europe, and we used to have, 4 brigade combat teams on base, and now we're down to 1. It's a difficult decision for a commander to decide which chow halls remain open and what kind of food they serve and when. And this all creates problems for our soldiers who are maybe working unusual hours, or maybe they have a 2-mile walk from the barracks to the chow hall. And I think the Army's been leaning forward on this issue in particular and trying to get to healthier food options and also have kind of a grab-and-go concept. And then for the military families, we're continuing to try to produce savings at commissaries and provide healthy options there. But the fact of life is that inflation has been severe in the last few years. Food prices are up. And if you have a large family and you're a junior enlisted, times can be hard. And so we continue to work on policy options to make sure that people have access to healthy food and that our service members have access to healthy food because, as we all know, the number one thing you can do to reduce medical expenses, to provide good health care, to have a healthy population is to make sure that people are taking care of themselves by things through exercise, getting outside, and eating a healthy diet. And this is probably something we should think about more from a DHA perspective as well, right? As opposed to just the military community lens. These things are mutually supporting. And I think that's a great question. I appreciate it. Sir, Glenn.
Mr. Hurst, good to see you again.
See you.
Glenn Deal, Defense Health Agency. I'm just wondering, as you see things, how does the military health system win the war for resources with the Defense Health Program?
Well, I think we're doing okay right now. We've been able to do pretty well, I think, in the current version of the budget review. We shielded DHA from some of the personnel cuts that were going to target others. We shielded DHA largely from the hiring freeze, and we even protected it from DRP, our medical providers. But we need advocates on the Hill, as you know. I believe in the House bill right now, there is some money that's set aside just for DHA. I think it's around $2 billion. That's still got to get passed. That's still got to get in our coffers in the Treasury. But that's a great win for this department and for our healthcare system. But I think it's about telling people what you need and what the true purpose is and making sure they understand this isn't just about healthcare, it's about readiness. Because again, if we can't provide for beneficiaries at home and people are going out on the network, it's costing us more money, right? We're going to bag two, we're having to pay more out on the network, and our providers aren't getting the sets and reps they need to actually take care of casualties in war and deal with complex patients. Thanks, Glenn. You have a follow-on?
No, just good to see you.
Good to see you.
All right. And sir, I think we've got time for one more question.
Yes, sir.
Hi, how are you? I'm Robert Ferry, the Deputy Surgeon General for the Guard. You have in the Guard and Reserve the 1/3 the life cycle asset cost for meeting the federal standards, and in the case of the Guard, the state missions as well.
Yeah.
And there's a lot of attention on billion-dollar or $2 billion line items. We just put out the RHRP 4 contract, which is going to be about another $1 billion. But there's a $110,000 cost to take the mobile PHA app that we can put in the hands of our soldiers to do their portion of the PHA before they get to, in my case, the Guard, a drill weekend where 20 guys are competing for 2 computers in the armory on a Saturday morning. And for $110,000, that is stalled, even though it's an Army or DoD-initiated effort to get a mobile PHA app that would offload some of the burden for our more expensive RHRP-type contracts. So when we look at those, getting those kinds of ideas, MacGyver, if you want to call it that, off of the shelf and into the field, how do you see cutting through some of that red tape?
Well, first off, I'd say come see me after this so we can talk about the app. I'm a current drilling reservist. I'm an IMA. And most of you probably know this, but you get 39 drill days a year as a reserve or guardsman that you're funded for, right? And I would say it's not uncommon for 5 of those to be taken up with medical readiness, which is a lot. I mean, one thing we're looking at right now, right, is currently we require people to go get a flu shot in the Guard and Reserve, even if they're not activated. And we pay you to do so. We take up a drill day for that. So making sure we're efficient about how we keep our Guard and Reserve soldiers medically ready, it's an imperative, and it's not just for our military health system, it's also for the Guard and Reserve, so they can optimize their time towards warfighting, readiness, lethality, the job training, right? And we're trying to do the same thing with our mandatory training. The Secretary signed out a memo, the Mission Focus Memo, which directed us to review the kinds of mandatory training we're required to do on an annual basis. Maybe we don't have to take cyber awareness every single year, right? Maybe we can spare ourselves that. Maybe we don't have to have combating trafficking in persons every single year. Maybe we give commanders the discretion to decide when their units need this based on the circumstances they're in and the maturity of their soldiers and the population, not just soldiers, but service members. So I think that's where we're headed. We're looking for efficiencies there. If we can do PHAs a better way, in a more cost-effective way that actually gives us more training time, we need to look at it. So I'll come find you after this and we can talk about that out.
Thank you, sir. I think you just hit a home run there. That's probably one of the most popular responses that you're going to give to a room full of medical providers to reduce the training requirements. But thank you so much, Mr. Hurst. We really appreciate your time and kicking off the conference in such a great way.
Thank you.
Thank you.
Enjoy this time. I know you don't get back together in person very often, and I hope to see you around the floor as I walk around today. Have a great day.